Well, hi, everybody. My name is Garrett Schmidt. I am the managing editor for BBC Exhibit Hall, and I would like to welcome you to today's live webinar hosted by Roji Health Intelligence. And I'm really excited about this one because there's a lot of really great information today, and it is called The Mystique of the eCQMs for APP reporting. And there is a lot of mystique and mystery about it. So our host, Miss Terry Hush, is going to put that into perspective for us today, and I'll introduce her in just a moment. A few items of note before we get started. Everyone has joined today in listen-only mode. So this is a traditional webinar format. You don't need to worry about muting yourself or turning off your camera or anything like that. But we do want to hear from you. So during the presentation at any time, if you have a question to submit, you can do that using your control module. There's a little area for questions there, and we hope that you do, because this is a great topic, and I know there's going to be a lot of discussion. And so we'll have a time for Q&A toward the end. If we don't get to yours, don't worry. Someone will get back to you with an answer to your question via email afterwards. So even if we're just wrapping up towards the very end, go ahead and submit your question, and we'll get to those as soon as we can. Today's session is also being recorded. So what's going to happen is when we're done, you will receive an email from one of us later this afternoon that will have a link to the recording, also to where you can download the slides, and there'll be all the information you need to get in touch with the team. Finally, I want to introduce more formally now our host today, which is Miss Teresa Hush, and who goes by Terry, and she is the CEO of Roji Health Intelligence, and she is going to probably do a little bit more thorough introduction of herself and her background, but wanted to introduce you at this time. So welcome, Terry.
Thanks, Garrett. I'm excited to be here. It's rare that you get to actually address a topic that's just floating around the gossip and rumor mills. And so that's what I'd like to do today, is kind of raise the level of gossip to go back to information. So let me get started with it. We have a lot of content, so I'm going to go through it relatively quickly, and I hope I do get a lot of questions at the end, because I'll be moving pretty fast. First of all, a little bit about Roji. We provide value-based care technology, where we've been around since 2002, and we came out of an academic center model with a big PHO that was doing contracting and clinical integration back in the heyday. And one of the things that distinguishes us, in addition to analytics and our value-based care technology, is that we are a CMS qualified registry for quality payment program reporting, and we report both eCQMs and CQMs. So I think you'll know what we're talking about today. It comes from a lot of experience that we have in looking at the different measures and the different data aggregation methods. So this presentation is for ACOs that are evaluating their paths to APP reporting, so that you know what you're getting into and can make some good strategic decisions. It's also for those groups that are considering the formation of an ACO, because this gives you a good idea of some of the main requirements and costs that are associated with that. And then last but not least, the IT staffs that are involved in the actual workload of the process of data aggregation. So what we'll cover is the eCQM Mystique. And so the rumor has it that eCQMs are the faster, easier, and cheapest way to do APP reporting, and that there's great advantages over CQMs. So I want to kind of correct that situation and tell you what really is involved in both of these different measure models, and then what's underneath the hood on the data aggregation part. But before we go, I'd like to do a little bit of polling question. I'm using a few of my dogs. And first of all, the A, the goofy golden, or the B, the puppy beardy. Do you favor A or B already before the actual webinar starts. I'd like to know who I'm speaking to and how to gauge the audience. So first of all, it's A, because I believe eCQMs are easier and automatic. B, because CQMs are the best way to get higher quality score. That's the Beardy. B, because the work involved gives me more value, and there's a lot of work in Beardies. And A, because I prefer goofy Goldens to bouncy Beardies. And last, I'm uncertain about whether A or B is smarter. Ask me after the webinar.
Okay, so I have put the poll up, and so go ahead and take a second to evaluate and answer. And we still have answers coming in, so I'll keep, I'll let it go for a little bit. And then I'll show the results here in a moment when we get all the answers in. Okay, I think it's slowing down. So in about 5 seconds, 4, 3, 2, 1. Okay, we're going to go ahead and close it out. And then I'm going to share the results. All right, Terry, are you able to see the results on your end?
Yes, I am able to see.
Okay.
Okay. Oh, well, that's really good. It's kind of evenly divided between strong beliefs and uncertainty. Yeah, goofy Goldens. Yeah. Fun. Anyway, you'll get to see a little bit more about of the dogs as we go through, because the pictures are predominantly from my stack. Great.
All right, I'll go ahead and bring this down.
All right, so let's go forward, and then we'll get into the gist. So the problem we have with either method is that the time for implementing APP reporting is really short, but the implementation process itself is extensive. So what is the best strategy for getting the highest quality scores at the lowest data aggregation cost and with the maximum value? Those are the three things that I think we're balancing. So again, high quality scores so that you pass with flying colors on quality, the lowest data aggregation cost, because that's the biggest cost in this, and then the maximum value to reach the other goals of the ACO. Those three things really focus on time, speed, and scores, and then the value for the goals. You want the APP reporting, because it is going to be at cost and a pretty steep cost for data aggregation, to fit into some other value for the ACO. And she's flying, right? She's a flying dog. The issue that we have on time is that the CMS web interface will sunset in a few years, but 2025 is the beginning mark of that year. You really need to be in a go position in 2024 to make 2025 work. And that requires a significant amount of advance planning and actual work in gathering the data. So what is the APP? Do a little bit of summary on that. The APM performance pathways, the quality reporting method for APMs, and it includes, this is the most important point, it includes quality measurement for all payers, all patients. What's different about it is that there's no more reporting on a sample of 248 Medicare patients only, which means that you really can't use a manual process of filling in data. All patients included regardless of payer, and for most ACOs, this means it's tens of thousands of patients rather than the 248. So the summary, less measures, way more patients. The active Reporting is required, though, on less numbers of measures. So it's diabetes, hemoglobin A1C, the screening for depression, and controlling high blood pressure. And then there are other measures that are calculated by CMS. So let's look at the advanced work. First, the APP measures require patient-centric results. That means that if you have a patient in the ACO who is seeing multiple practices in the ACO, especially as a lot of ACOs include specialty practices in addition to primaries, you will have to match that patient across the entire organization in order to produce a valid result for reporting. So that patient has to appear only once for the measure. Secondly, the APP measures must include the entire population of those patients. So if one of your practices, for example, has a hard time collecting data or can't do QRDAs and you're looking for some other method, let's say it's a cloud-based system, it isn't an option to simply leave out that practice and report on the rest. Everybody has to be included in the reporting. So if you thought that CMS claims was kind of a backdoor possibility for you to make sure that you had the correct patient matching, or you could use perhaps the patient ID under Medicare, well, the fact that the CMS claims are only for Medicare and that most of the commercial payers are not providing claims leaves you out in the cold in that one too. And there's no unique patient ID number that's coming out of various systems. So really your patient matching algorithm has to be constructed by your vendor, or if you're planning to do this on your own, which I would not suggest, by yourself. So the conclusion is to track a patient across the continuum of care, your ACO must aggregate its data and match patients across the ACO. It's worth mentioning that the APP is also the basis for measuring equity, according to CMS. The reason they're really sticking with an all-patient, all-payer kind of methodology here is they are moving into evaluating simultaneously health equity and quality. And the APP data, because it gives you a holistic view of all the patients in the ACO, is primed to do that. So the decisions that you face going into this are, first of all, what measures do you report? How do you get the data for the APP? And how do you optimize the APP effort to achieve your other goals? And so it's the same thing. What measures, what are you doing? How fast can you get it done? And what's the value? So let's look at the two kinds of measures. The eCQMs are all about the flow of data. They capture the EHR system data to fulfill the measured denominator and numerator for each patient. And the form that those are captured in is called a QRDA1. It is specific to the patient and has a patient identifier attached. Then the system, and this is how it works in a one system only situation, then the system itself feeds through all the QRDA ones to produce a QRDA3 for electronic submission to CMS. Now that's how it works when you're only working on one system. That second part, the QRDA3, isn't available to you under the APP reporting mechanism unless you have only one system that captures all of your providers. ONC-certified systems can report eCQMs. So they have the machinery inside to produce the QRDA1 and to turn it into a QRDA3 in the aggregation process. So here's the picture of the data flow. It's just from one to the other all the way through, and it never quite goes that perfectly. Oops. Now I want to move to the next slide and it doesn't want me to. CQMs are about the flexibility of data. Data can flow into the technology in multiple ways: QRDA1s, flat files, direct entry, interfaces, other reports. So one of the big benefits of non-QRDA reporting is it's cheaper. Flat files are about 1/3 of the cost than QRDA1s to process. Well, why? Because you have a transfusion of the code, if you will, from the QRDA1 XML format into a format that the other technology will accept for reporting. The other thing is that registries typically integrate multiple sources of data to achieve the best scores for clients. So in our example, for example, we will find an organization where a lot of the A1C scores are missing for patients. We go back to the client and we say, you know, we're not capturing A1C scores for these practices, and they can figure out what caused the problem in the lack of data flow through into our data capture, the flat file, and go back and produce a special report, and then we can incorporate that. So under CQMs, you have the ability to continually improve your score until you're actually reporting it. And certified systems can report CQMs as well. But there's one thing about the measures that you need to really be aware of, and that is that the eCQMs and CQMs, although the measure statement is identical, they each act differently, and several factors in those will influence your results in APP reporting. So first of all is the time frame. The time frame for the diagnosis, or when the measure is triggered, differs between eCQMs and CQMs. For a CQM, the diagnosis can appear anytime. It can be a year old or 2 years old. For an eCQM, it has to appear within the performance year. So the effect of that is that if you have, especially since we're dealing with chronic disease in 2 of these measures, a patient who has well-controlled conditions doesn't show up within the performance year period. It could be, you know, a couple weeks give, who doesn't show up within that performance year, the data doesn't show. But also, if they do show up and the diagnosis was not coded, then it doesn't generate the response that will help the client do better. Whereas if a CQM had been deployed, that CQM would have captured the data and shown good results. So especially in a control measure where you want a certain percentage of your patients to appear as in good control, this has some pretty big effects. There are also differences in the data aggregation that affect the results. The eCQMs are automatic, but that doesn't mean that the data is stored in the place where you are pulling the data from. And why would that be? Well, many practices create special templates for managing workflow in the office. So a big group may have multiple different templates, but the actual data for blood pressures or for hemoglobin A1C may be stored centrally, but when they have templates, they're also stored in the template instead. So the data doesn't flow easily, and that's what leads to data being missing when you look at these values. Another situation is the actual implementation and standards in use by providers in these practices. So there could be free text notes or scanned PDFs, a lot of PDFs, and customized features in the EHR that all turn out to be fails in the eCQM measure. CQMs permit alternative methods of entry and file structures, so you can go back and capture that information retrospectively. There's also differences in the measure completion requirements. So CQMs have a minimum requirement for completion of the entire measure, and that's 70% of eligible patients. And those patients are the ones that are evaluated for performance. So the performance application, which may look like, let's say 90, 95% for CQMs, has a different comparison to eCQMs that don't have that option. The missing data is simply a performance failure because there's no completion threshold in eCQMs. But the benchmarks that are deployed for the measure are partially reflective of the understanding that the data is often not in the EHR to complete the measure. So the threshold is often lower in some deciles of the eCQM. There are different benchmarks that are the final adjustment to scores. So when the eCQM data is missing or stored elsewhere, the actual calculated measure result will be lower, but it could be that they're in a particular decile, which will raise the actual performance. But the effect of the completion factor overall raises CQMs to a higher level than the performance level that usually occurs in eCQMs. So a summary of the actual measure differences. The CQMs, sometimes they're more work because you're looking at multiple files. The IT staff may have issues initially with how they would go about capturing the data. But we have found very few problems overall with any kind of flat file data collection. It gives you greater control, greater likelihood of success if there are multiple practices, EHRs, and performance variation, and definitely different kinds of installations all benefit from CQMs over the eCQM. The eCQMs are sometimes better if the data is actually perfect and there are no templates and it flows easily into the EHR. The problem is you're not going to know going in which is better. You will never know until the actual result is there what can produce more points. So you can test what works better. You can ask your registry, for example, to do both QRDAs, or they can do and compare that. But doing so across the entire organization would essentially double your cost, and that would not be prudent. The next thing I want to look at, though, is the real elephant in the room, because part of the reason that the eCQMs are thought to be automatic is that people are fearing what's behind in data aggregation, how hard it is, what's involved in it, etc. That's because data aggregation is really new to ACOs. Most ACOs have not done it. They don't really have familiarity with the data in EHRs and where it is. There's a lack of knowledge about the different EHRs and how difficult or easy it is to get the data from. There's a belief that every certified system can provide a QRDA one. That's a big issue because it's really not true. The EHR is designed to move QRDA ones into a QRDA 3 mode, but not all of them can produce a QRDA 1 outside the system. So that's an issue that has to be resolved with multiple systems. They may be able to find a way of doing it. Whether they can find it within the time frame is a question. There's also an underestimation of the difficulty of patient matching, because once all those QRDA ones are collected, you still have to provide the patient matching and choose the latest value according to the measure requirements. And then finally, I think one of the big issues on data aggregation is looking at quality reporting as a data exercise. So the only cost and the only value that's being determined is how fast and easy can I make quality reporting, and not what do I need going forward in data as a way to excel as an ACO. And we'll cover that a bit. So eCQMs are tied to QRDA ones. That's the only automatic flow of data from practice to reporting. And the QRDA models in EHRs are built to collect data from predetermined fields. They are only specific to the measure. So you are not going to get a QRDA fed database that will give you anything more than what you ask it to produce for the measures that you want it to produce. That means that the QRDAs will not help you with any of the analytics that you might have to do going forward. They won't help you to model measures or other payment models or risk going forward, or to stratify the risk of your patient population. They are simply a method of providing the data for QPP. The first problem with QRDA ones is they're really not available to ACOs for many EHRs. Some of the EHRs are not certified, some of them are out of date, some of them are simply unable to produce the QRDA ones. And if just one of the practices EHRs cannot produce a QRDA one, the whole data aggregation process, or the eCQM linked process, fails, because you will not be able to do eCQM reporting for any of the organization if one fails. The second problem is that they really are more expensive. I mentioned 3 to 4 times, and that's our experience. They take longer. They are resource hogs. So even though they are a small amount of data, that data is configured in a way that is very expensive to process. And it's just a hard thing to imagine why such little data could be worth the effort that goes into it. So where do you begin? Does anybody, I wonder if anybody knows where the head of this beard is. And the beginning is always at the head, right? The first thing you need to do is test your assumptions about QRDA capabilities on your reality. So before you adopt eCQMs that require QRDA ones, ensure that each system can actually produce it. That means going to your various practices and asking for the production of that. Many of them will not have the technical staffs that can do it, and will need to involve their vendor. But at least you will know coming out of that process whether it's a reasonable alternative for you to pursue. The second possibility is just simply using flat files to aggregate data for CQMs, and then compare the results with a sample of some part of your eCQM practices, so that you can see what the results are. And that would be really important for those practices that are, let's say, have a number of specialists in them, so that you can see whether you're actually collecting blood pressure values, for example, from cardiology or some of the other specialists under your QRDA1 model. The next issue is to ensure that your ACO and your APP will be successful together. So you want to be able to examine your performance results to reveal inequities. I think that we can all count on the fact that health equity measures are coming down the line, and it will also require all of your patient data to be able to evaluate that. You should consider your data aggregation method first prior to how you are going to report, since they're so linked. Since you can only report eCQMs if you have QRDA ones, and you still have to make a decision based on the value of the QRDA ones, it makes sense for you to make that data aggregation decision prior to making a decision on how you're going to be reporting. And have a really good understanding of the value of the data you're currently using now to fuel your population health initiatives or your coordination of care, and whether you're in the future going to be looking at other data sources to do that. Whether you decide to report eCQM or CQMs, you need to provide support to practices by closing this data leakage. That's going to be a more and more central role of the ACOs. As you get into data aggregation, you're going to be getting into support regarding data aggregation as well, and improving their data sufficiency so that that data can flow to you to do a better job on their behalf. The peak performance in ACOs is all about value. You don't want to adopt strategies only because they seem easy or that they can achieve APP reporting. Data aggregation is way too expensive for using it for APP alone. So you want to determine your approach based on the maximum value of the data for all of your data-driven initiatives. Your best strategy is to first understand your data sources and data aggregation. We've seen a lot of ACOs start the process, for example, putting out a reporting RFP, but not having even a list of the systems in use by their practices, and not understanding what kind of data aggregation is behind that list of EHRs. That's not the way you really want to start this planning process. You start with evaluating the practices that are in use by your systems or your practices, and which systems they are using, and then what system capabilities are present in those practices. Then you can decide how you will do the data aggregation, what resources you will require, and following that, what you'll want to report. If you actually are successful in collecting the eCQMs and your results turn out to be low, you can always go back and determine by the extraction of additional flat file data whether you can move to CQMs at a later point in time too. So it isn't a closed scenario if you want to improve your results, but you have to start with the process of getting as much data as you possibly can. And that should put us in position for questions.
Okay. Well, this was a very interesting and very in-depth conversation for sure. And so I know that there's a lot of questions swirling around out there, and we do have some questions that actually came in. So I'm going to start in no particular order. And if, by the way, if you have a question that you would like to submit, please go ahead and do that now. And you can use your control module to do that under the questions area. And so we'll get to as many of these as we can. I think we've got some time. So starting with this one, why are QRDA one files more costly to process than other sources such as a flat file?
QRDA ones are XML formats, and XML requires a conversion into a different format in order to go into a registry measure. And that's the simple answer. It takes a lot of power to do that conversion and to make those files fit the way the measure specifications are.
Okay, great. They just showed up and decided to pressure wash the side of the room that I'm at. on the outside. So I apologize if there's any ancillary noise here. They always know when I'm doing a live webinar. Next question here is, you said that QRDAs have limited data. What do you mean by that, and what data is missing?
If you're looking at a flat file, let's say our flat file specs that we ask for clients include about every piece of information that you would ever want to analyze. They include all diagnoses. So I don't mean just, we're putting it in a database that is longitudinal. So we're collecting a long history of what the patient has and the problem list of the patient, all the blood pressure values of the patient, hemoglobin A1C and all the markers, staging data for cancer, all the different procedures that the patient has been into. So when we, at the end of that process, we're able to produce analyses of many different types for an ACO or a group. And we do that routinely. We create episodes that help people look at variation in care and so on. A QRDA document will have the hemoglobin A1C, most recent data, and the patient information. And that's it. So you can only use that document for the measure.
Great. Next question here is, let's see, and they preface by saying maybe this question should be saved for later, but no, I think it's a great question. But I would expect that with the government moving towards electronic everything and ONC as well, shouldn't we expect that eventually the requirement will be eCQMs?
I don't think so. I mean, no, I don't think so. I mean, for example, we're certified. We're certified registry. We are ONC certified. I mean, we can report eCQMs, but our clients do better for CQMs. And I think CMS has always tried to be fair in understanding the status of actual data. So otherwise they wouldn't have created two different kinds of measures. No, do they want it to be an option to be efficient? Yes. But I think again, the issue is beyond quality reporting. It's about having the data to do more than quality reporting and actually improvement programs.
Well, I think that's a great answer, and yet to be determined in many respects. Okay, going on to the next question here. QRDA1 files. Can you explain how they are obtained? Is it from an EMR billing company? Is this different than an 837 file?
Oh yeah, it's not on 8. Yeah, the other, what you're referring to are billing files versus actual electronic record files. So the QRDA ones are produced inside the EHR, and they go out and capture the patient who qualified for a measure and the value reported for that patient with that measure. That's it. They are in most EHRs, they are then automatically pushed into the engine that aggregates all of that data and submits it to CMS. And that happens in regular practices, not ACOs, but in regular practices, though practices do not have a view about their quality measures until they're actually reported at the end of the year. So they can't fix it. I think there's a big question for a lot of the, let's say, first generation older EHRs, whether they can produce the QRDA ones or not. We've seen great difficulties. We see difficulties with a lot of our clients that have converted from other systems onto Epic when it comes to producing QRDA ones, because they want to give those to us, they have a hard time getting them. So there's a big learning curve, and it's done by the practice. You can't get a billing company to extract a QRDA one. It has to be either a report that comes out of the EHR natively, or it has to have an ability for an IT staff to create that from the EHR.
I think that's a great question. Great question, great answer. Okay, next question here is, would an entity or organization have to use an outside expert, such as your company, to aggregate and submit CQMs?
I think that whether it's CQMs or eCQMs, you're talking the same thing, then my short answer would be yes. You need a measures engine to do quality reporting that's across all patients from multiple practices. It would be extremely difficult for an ACO to internalize the patient matching and measures algorithm that's required for measure reporting, even for only 3 measures. We go through a testing process of that with CMS. We're validated every year on that. And I mean, we have to apply every year and get, we can be audited. All of those things are part of the process. And plus, since we're ONC certified as well, we're going through that testing process on a regular basis. So yes, I think that no matter what you do with data aggregation, for quality reporting, you will need a registry to report that data if you want to get the best value.
Yeah, those aren't waters you want to swim into on your own, for sure. Okay, next question here is, how do you handle offices that maybe don't have an EMR of any kind and are on paper? And second part of this is, how do you handle ACOs with multiple EMRs rather than a central EMR?
Let me take the last one first. So multiple EMRs is what we expect. When we were doing, I don't know if you're familiar with the whole clinical integration that predated the ACO movements, but this is before larger EMRs were really capturing the market. We would have as many as 250, 300 different data sources for one client, because every practice had a variation of some EHR. And so we worked out methods with EHR, with each practice and or each EHR of collecting that data. Now it's a lot easier because we use flat files predominantly to collect data. We also collect a lot of QRDA ones, and we collect other kinds of data that practices send to us too. For example, they want a project, and so they sent us an Excel spreadsheet of data, and we're incorporating it, or a CSV file. But it's very difficult when you have a practice that is still on no EHR. I think that ultimately the practice is going to have to get on an EHR in order to do business with your ACO. That's the way the world is moving. And unless there is some manual entry system for every single patient who came into the office and qualified for those measures, which is conceivable, our system has an input capability. People only use it if there are reasons to catch up at the end of the year and the scores were invalid. They don't use it routinely. But it's possible to use a data entry system if it captures every single patient, and you can verify that it captured every single patient by taking data from transactions and visit information and then cobbling together a method of capturing that data. Hard and expensive, but I wouldn't want to be doing it.
So
I'd
it's
be pushing them
possible.
onto it. I would be sponsoring an EHR for the organization of practices that didn't have anything.
So
That's
not
what organizations are doing. They are letting practices ride on their systems. They're sponsoring common systems. I've seen it happen with just about everything, even Epic.
great.
And that's probably the best practice. Instead of the whole world going towards eCQM, I would say the whole world is going towards a data aggregation model where the value of data is seen to be so important that data aggregation and sharing will become more common and people will combine systems so that that can happen.
Right. Okay. The next question that came in is kind of a statement, but I'm curious to hear if you have any comments about it. Is they say, as an aside, eCQMs can be monitored outside of the QRDA one files. Is that correct?
I don't know what this monitoring means. I mean, we're collecting QR. You have to be able to take the data in electronically and output it electronically in order for it to qualify. If there's another mechanism that they're using, I don't know what that is. It's QRDA ones are the standard for the measure.
Okay, cool. Next question here is, what is motivating this deeper dive into more complex and comprehensive quality reporting?
Many things are motivating it. One is it's the standard for the rest of Medicare. In MIPS, it has been all patients for, well, since MACRA was introduced, it was maybe 2015, 2014. So all of the quality reporting has been all patients, and the other part of Medicare, the non-ACO part, for that long a time. And so they're used to it. It's the ACOs that are the outliers, and they're supposed to be the model of good care, and yet the reporting is on 248 patients. So it's not really seen as appropriate as far as comparison is concerned. The second thing is, as I mentioned, health equity. As health equity is beginning to drive the issues as much as outcomes and quality, looking at these same measures and evaluating them from a health equity standpoint is going to be equally important. And you can't do that on just a small number of patients. You fall into traps in, how many Medicare patients the practice has and so on. So health equity is being driven by an all-patient approach universally. Those are the two things that I think are driving it the most. I think the other thing is that this is in the world of data analysis, you can't really look at a small slice of patients and identify cost variation, cost drivers, improvement programs, change practice styles for physicians. Physicians are not going to engage if all they are caring about is a small part of their practice. The whole name of the game has been practice transformation, changing the way people are thinking about care, moving towards wellness and prevention as opposed to treatment models. All of that depends on doing it across an entire practice with all data. And so the whole industry is moving towards this. AI is built on this framework as well. So there's no future that I see at all in limited one slice of the pie, data-driven healthcare.
Yeah, very good, very good. Well, that is actually, that wraps up all the questions that we've had come in. I know there's a lot of questions out there still swirling around, and you may be even in a position where you don't even know what questions to ask, which is fine as well. So don't feel bad, but Terry, and I'm going to tell you how to get in touch with her in just a moment, but they'll be able to continue to clear up anything for you, and they'll be here for you in that regard. As we conclude, and Terry, I just want to say thank you so much. This was a wonderful presentation, a lot of good stuff here. Someone had asked earlier if the recording will be available, and it will. And we're going to be sending that out here shortly afterwards with a link also to where you can download the slides. But as we conclude, I wanted to encourage you to stop by the virtual booth, exhibit booth, that is at VBC Exhibit Hall, and it is a great place that you can interact with the Roji Health team. You can do a deeper dive on many of their resources and thought leadership. And Terry puts out an excellent blog, which we feature a lot of her material in our newsletters, but she's very prolific on a variety of different topics. So definitely encourage you to check out her blog as well. And you can do that. There's a direct link to that on the booth. And the slides will have a link to this booth where you can go as well. And then finally, if you would like to reach out to Terry directly or to the Roji team, you can do that here. Dan Cronin is in business development, and he will be happy to also point you in the right direction and take any of your inquiries. And of course, Terry is there for you as well. And if you would like to, feel free to reach out to me. I'm happy to facilitate an introduction if you would rather do it that way. And of course, if you have an RFP to submit, this is where you would want to do that. So thank you all so much for joining us today. This is a great session, and I hope that you join us next time. Thank you again, Terry. Have a wonderful rest of your day, everybody.
No, thank
Bye-bye.
you, Garrett. I've enjoyed it.
Very good. Bye-bye.